Carbon dioxide is a byproduct of cellular metabolism and it is transported in the blood in three ways. So it goes from your tissues, right? So your every time your cells does something in its metabolism, it produces CO2. So it needs to be dissolved in the blood and diffuses into the red blood cells. And it is transported by the blood in three ways. It is dissolved in plasma. If you can see in the picture there, it's a 7%, but it's 5 to 10% of the total carbon dioxide dissolves in the plasma. It is dissolved as it's dissolved as bicarbonate, 60-70% of that, and as carbaminohemoglobin, and there's 20 to 30% of the CO2 is transported in that manner. The greatest bulk of CO2 transport is the bicarbonate form. The most important of these is the bicarbonate ion. Bicarb ions are formed from the combination of CO2 and water. So when your cells produce CO2, it combines with water and it produces carbonic acid or H2CO3. And then that carbonic acid breaks down into HCO3 and hydrogen. It breaks down. So carbonic acid is formed when CO2 is produced by your cells. It combines with water and it turns into carbonic acid. That carbonic acid breaks down to bicarbonate and hydrogen. And remember when we were talking about the oxyhemoglobin curve, that when you are alkalotic, you shift to the left? Well, when that means that you have too much bicarbonate in your system. So as you can see here, this is kind of how these processes work. In the lungs, the reaction reverses direction and CO2 is formed and then it diffuses into the alveoli and then you breathe it out. So let's take a look at the alterations in pulmonary function. Hypoventilation occurs when there is not enough delivery of air to the alveoli. Because you don't have enough air in the alveoli, then you don't have enough oxygen that is delivered there. And also, hyperventilation is not enough, it's not sufficient to remove CO2. Remember how I said that when you're respiratorily depressed, and that means that you're not breathing out CO2, so it accumulates in your bloodstream. This is, it can be influenced by you not breathing enough, decreased rate, so slow respirations, or not enough depth of respiration. So shallow breathing is not enough. So it will still be hypoventilation because you're not breathing enough. You're not taking enough of a deep breath to suck in air into your lungs. Hypoventilation results in increased PaCO2. It'll be greater, so your PaCO2 will be greater than 45 millimeters of mercury, called hypercapnia, if we did arterial blood gases. So what are some of the causes of hypoventilation? It could be from drugs like narcotics and benzodiazepines like Ativan or midazolam. Sleep apnea causes this also. In a trauma situation where the chest wall is damaged and that chest wall can't move that much, or it's damaged enough that the patient can't breathe, um, can't take deep breaths, and or is not breathing enough. So any kind of pain related to surgery, because when you're in pain, imagine when you get hit in the ribs and you don't want to breathe because it's so painful, right? So that can also cause hypoventilation. Hyperventilation is an increase in the amount of air entering into the alveoli. When you're really nervous and you're like, you're hyperventilating, it's like a dog panting, that's hyperventilating, leading to hypocapnia, where your PaCO2 level in an arterial blood gas will be less than 35 millimeters of mercury, and that's also termed hypocapnia. What are some of the causes of this? It could be a hypoxic stimulation of the peripheral chemoreceptors. Pain can also cause this. Fever, definitely. You're trying to blow off your CO2. pain, you kind of pant like a dog, they pant. And anxiety are common causes of hyperventilation. Less common causes of this are obstructive and restrictive lung diseases, sepsis, and a brain injury can also cause hyperventilation. Okay. Ineffective gas exchange from a failure to ventilate occurs when there is an adequate volume of gas, but it's maldistributed, meaning it's not going to where it needs to go. In the healthy lung, some maldistribution of gas occurs because of gravitational forces on the lungs. We talked about that when you are sitting upright, the gas distribution is not equal throughout your lungs. You get more ventilation on the bottom. And then when you're laying flat, it's the same. You get more ventilation on the bottom, and the tops of your lungs, whatever is up higher, is not getting as much ventilation. So that's maldistribution of gases. In in obstructive pulmonary diseases, um, no, let's talk about emphysema first. Emphysema is because there's some damage to the lung tissues, and in this case, um, there's gas exchange occurs only in some alveolar units because there's damage to the tissues in emphysema, and so some of the gas exchange doesn't happen at all in those damaged areas. In obstructive pulmonary diseases, there is increased airway resistance, and this develops in localized regions because, well, there could be some obstruction in some of the airways, like you have increased sputum production or there's mucus in there. Or it could also be what they call mucosal hypertrophy, where the mucosa are kind of swollen and there's edema in there, so there will be increased resistance. There could also be some kind of loss of structural integrity of the airway, like if it's damaged in a trauma situation. Any narrowing of the airway from bronchial smooth muscle contraction, like asthma. So, those are the kinds of things that maldistribute gases. Two terms frequently used in discussing decreased PaO2 are hypoxemia and hypoxia. Hypoxemia refers to the deficient levels of blood oxygen, and low hemoglobin as measured by arterial blood gases. Hypoxia refers to a decrease in tissue oxygenation. Tissue hypoxia is kind of difficult to measure, but we can measure that if your blood flow or your PaO2 is abnormally low, then there's probably you probably have hypoxia. So there are different kinds of hypoxia. There's actually four. There's hypoxic hypoxia, anemic hypoxia, circulatory hypoxia, and histotoxic hypoxia. And we'll talk about those. Hypoxic hypoxia happens when the PaO2 is decreased, even though there's normal oxygen carrying capacity, meaning that you are not anemic, you have enough blood cells, but for some reason, you're still not getting enough oxygen delivered to your tissues. What are the causes of this? So you're at high altitude, like you go to Haleakala or Mauna Kea, and that's high altitude if you're not used to it. And so at high altitude, oxygen, when you hear the air is thin, it means that the oxygen is kind of distributed much further away. So it's not that there's less oxygen, it's just that they're dispersed kind of far away from each other. So every time you breathe, you're breathing in less oxygen. And so that's why you feel a little bit hypoxic, because there's not enough oxygen that you're breathing. This actually happened to us when we were up in the air transporting a patient and the cabin decompressed, and I was feeling very, very dizzy. We were up at high altitude. I think we were up at probably 13,000 feet. That's the height um, where you jump out when you're skydiving, which is pretty fun. But if you're not used to the high altitude, of course, your lungs are going to complain. So high altitude can cause hypoxia, hypoventilation, where you have enough blood running around and your blood cells are picking up oxygen like they're supposed to, but you're just not breathing enough for whatever reason, which we talked about. And airway obstruction can also cause hypoxia because, again, you're breathing in air, you have enough blood cells to transport them, but there's something in the way to transport oxygen so you can use it to your tissues. Oxygen therapy usually provides adequate treatment for this, so it's not that hard to fix. Or in the case of high altitude, you got to descend. That's all you can do. Anemic hypoxia results from a decrease in oxygen carrying capacity. Any disorder that causes low hemoglobin concentration can cause anemic hypoxia. So somebody who has issues with if they have low iron, low folate, low B12, because those you need those things to make blood cells, red blood cells. So those are just examples that can cause an anemic hypoxia. How about circulatory hypoxia? So circulatory hypoxia results when you have low cardiac output. And so, of course, low cardiac output, we talked about this already, and I know I keep repeating myself. Low cardiac output, not enough blood being pumped out by your heart, meaning that you don't have enough blood cells, hemoglobin to bind with oxygen. And so your O2 carrying capacity is normal in circulatory hypoxia, but the blood flow is reduced. So, examples of circulatory hypoxia include shock, cardiac arrest, obviously, right? Because your heart's not moving, so there is no cardiac output. Severe blood loss, and there's a thing called thyrotoxicosis and CHF, congestive heart failure. The last classification is, not last but not least, is histotoxic hypoxia, which occurs when there is an interference of a toxic substance that leads to the inability of your tissues to use available oxygen. Like cyanide poisoning is an example of histotoxic hypoxia because it prevents your um, I'm having a brain fart. It prevents your blood from using that oxygen that's available to it. I know I was going to get it out eventually. So ineffective gas exchange occurs when ventilation and perfusion do not match. My computer is having a seizure. What's it doing? There we go. Finally. Ineffective gas exchange occurs when ventilation and perfusion are mismatched. When diffusion abnormalities exist and there's that problem with shunting, what do we call shunting, during periods of normal perfusion, not all capillaries are open. So the capillary system has the ability to recruit or open up more capillaries and to distend as needed. And I think we talked about that in the blood flow. Okay. Come in. Okay. Acute respiratory failure. How does this happen? Well, acute respiratory failure is a state of disturbed gas exchange that results in abnormal blood gas values. So you will see a PaO2 value that's less than 60 millimeters of mercury. And remember that at 60, your O2 sat could be reading 90%, right? It doesn't sound that bad. I mean, 90 to 100 usually is an A, right? But not in this case, because 90, your O2 sat of 90 only gives you 60 millimeters of PaO2, and that is considered hypoxemia. So we don't want that. So acute respiratory failure also gives you a PaCO2. Gosh. A PaCO2 that is greater than 50 millimeters of mercury, that's hypercapnia. That means that in acute respiratory failure, you're not breathing enough, or CO2 is accumulating in your blood, and that's more than 50 millimeters of mercury. And your pH, because remember that I said when you have CO2 accumulating in your blood, it makes you acidotic. So the pH is less than 7.3 when the patient um, is in respiratory failure. Those with failure of respiration or oxygenation leading to hypoxemia, and then you have those people with failure of ventilation leading to hypercapnia, and those combined together, you end up with respiratory and ventilatory failure. So, how does this happen? So, not really sure how acute respiratory failure, I guess, occurs, because it kind of depends on the causes or the cause of the disease process. There's there's a list of conditions in your book. I think it's box 21.2 that show you what can cause acute respiratory failure. So make sure you take a look at that. But the most common lung diseases causing acute respiratory failure are advanced emphysema, pneumonia, asthma, pulmonary edema, and ARDS, acute respiratory distress syndrome. And this is the ones that we saw when we had all these COVID patients who were really, really sick. And ARDS is very hard to kill. It just basically makes your lungs like cement, and it's very, very hard to oxygenate it. In general, the development of hypoxemia is related to bad ventilation and perfusion. So ventilation is getting air into your lungs, and perfusion is that, right, the exchange of gases. So when those do not match, then you get hypoxemia, and when that gets worse, then you have respiratory failure. So what do we see? What kind of clinical manifestations do you see? My computer is really slow. So what you're going to see, it kind of depends on what it is that's causing the acute respiratory failure. How do we diagnose this? So we said that when you have when you take arterial blood gases, the common findings are your PaO2 is less than 60 millimeters of mercury, and you have a PaCO2 of greater than 50 millimeters of mercury, and that's without any oxygen. And then also, we take a look at your chest x ray and see if it shows anything on there. So, So, what do we do in acute respiratory failure? Well, what we really want is to maintain ventilatory support to make sure that the patient is ventilating enough, because without ventilation, you're not going to get oxygenation. Okay, so we want to maintain ventilatory support by maintaining airway patency and making sure that there is enough ventilation to the alveoli. And many times in acute respiratory failure, we just intubate them. We essentially just breathe for them because they're not doing it themselves. So, treatment of the underlying condition, so whatever it is that caused them to go into respiratory failure in the first place, we need to fix that. So if it's a pneumonia, we need to fix that. If it's emphysema, we need to fix that. So whatever it is. And supportive care, meaning, is there anything else that we need? We need to fix all of those. So let's take a look at pulmonary hypertension. Sorry, my computer is having some issues this morning. I think it needs coffee. So, what is the cause of pulmonary hypertension? The cause of pulmonary hypertension is sustained increase in pulmonary artery pressures. So the pressures in your pulmonary arteries are so high. It's above 25 millimeters of mercury, and it goes up to above 30 millimeters of mercury when your doing activities like exercise. So there's two types, there's primary and then secondary, and you don't have to know any of that. So how does this happen exactly here? Gosh, if my computer will move forward. Okay. So what happens here is that there could be some issues with your pulmonary vessels, the small pulmonary vessels. They could thicken up, of course, so that, remember again, that with that thickening of the vessels, it makes that lumen, the radius, smaller. So it increases resistance. So it's harder for air to get through. So it becomes that internal layer of the pulmonary artery becomes very fibrotic. And then what happens there is you have muscle development occurs in the vessels, and those vessels are usually not very muscular, but they do. So what happens are, big giant muscles that kind of constrict, again, the airways. There could be some plexiform lesions on there that forms, and then you end up with tissue necrosis, and hemorrhage often occurs because of that very high pressures. And then what they do is they start to leak out. So pulmonary hypertension is not a good thing. We need to fix that. Um, and and I, if my thing would go forward, we're not going to talk about the treatment of pulmonary hypertension because we're going to talk about that in 360 in detail. How about PEs? Well, there's pulmonary venous thromboembolism. Let's see here. And in this case, how does this happen? Well, we talked about thrombi that decide to go surfing in the bloodstream, right? So pulmonary venous thromboembolism is from undissolved detached material that occludes blood vessels in the lungs. So, Lord. Once blood clots are released into the venous system, they travel to pulmonary vasculature, and we kind of talked about this already. So blood clots, thrombi go surfing in the bloodstream, it gets lodged in the lungs, and so you have pulmonary venous thromboembolism. And of course, it depends on how big these clots are and where they lodge. But essentially, if you have blood clots that goes into your lung vasculature and occludes them, that means that your lungs are not getting blood and they're not getting oxygen. So, think about what happens when you don't get enough blood anywhere. How about lung cancer, pulmonary malignancies? Well, in this case, there's all these major types here. You can look at it. We're not going to go over every single one of them. It just depends on where they are. But let's see here. Okay. Yeah. I'm not going to go over it. You don't need to know every single type of lung cancer. But the important thing to remember is that lung cancer, those cancer things they're masses. So they can form anywhere in the lungs. And because they are masses, they are lesions, they call them, then they can cause blockages. So wherever they are, they can cause a blockage to air going into your lungs. They can cause blockage of blood going into your lungs. So anywhere they are, they can cause either a blockage for air to get through or blood to get through or both. That's why they're not good things to have. Right? And unfortunately, a lot of lung cancers, you don't really know until it's too late because, unfortunately, cancer isn't painful immediately. All right, well, that wraps up this whole PowerPoint, and then we'll go to the next one.